You know, I think when we even think about our own consultations, we tend to get quite distracted by the outcomes we were trying to achieve and the diagnosis and management, and it can be quite difficult to reflect on what actually went on in the consultation. So I just want to talk quickly about some of the ways we can observe a consultation and structure our feedback and observations. So I guess at a simple level, we can think about the what of a consultation, what information was collected, what was the diagnosis, the range of diagnoses that were considered, what was the management that was considered. And this could be maybe structured in the consultation mapping model. You know, generally the doctor will introduce himself to the patient, they'll take a history, perform a physical examination, define the problem, work out what investigations need to be done, make a management plan, consider safety netting. And you generally find registrars who are early in their training will be very focused on the what of the consultation and be concerned about their clinical knowledge and whether they're covering things. But then there's also the how. How is a doctor running the consultation? What did they actually do to elicit the information from the patient, to explore the history, to check that the management plan was actually practical for the patient? And this becomes a bit harder to define. A lot of this comes into communication issues, and you may find yourself focusing when you do observed consultations on the communication issues. For instance, is the doctor asking too many closed questions, maybe not using closed questions at the appropriate time? What sort of language are they using? Are there language barriers? Are they using too much jargon? It's a great opportunity as an observer to observe the body language of both the doctor and the patient and give some feedback. And in fact, one of the things that we insist on at NTGP is that every registrar does a video ECT visit at some stage where they video consultations that they do with patients, and it's a great eye-opener for the registrar when they see how they're actually coming across, and they often pick up things that they didn't see in the original consult. There's often issues where the doctor is very focused on their own agenda and not addressing the patient's agenda. That can be reflected on. There may be cues that the doctor's missed. Reflecting on the emotions of the consult often comes in it with registrars who are a little bit more advanced and have the clinical issues fairly sorted, but it becomes very interesting, and I guess that's one of the reasons I enjoy doing external clinical teaching visits, is helping registrars explore some of these non-verbal issues that go on in the consult, and registrars often get insight into how the emotions of the patient and themselves are affecting the consult.